Welcome back to Pharmacology. We continue our discussion of toxicology. We first of all wanted you to appreciate, as you do your research, how very broad toxicology is. So we said, as you're researching just a couple of examples, don't think you're going to find every dose estimate or every margin of safety measurement for your particular toxin. What you find is what you find. And there were some, though, that had this unusual U-shaped dose response curve where you may actually get the raw data and not just one of these processed parameters that are representative of the whole raw data and are used as a dose estimate of risk. So now that we know the risks of toxins and how that risk is measured, there are some other aspects of toxicology to consider, and also, once again, we'll take it from the point of view of helping you revise some of the pharmacology material, given that pharmacology comes under the banner of toxicology. So we're going to review, to some extent, absorption, distribution, and excretion of drugs while we talk about absorption, distribution, and elimination of toxins. We talked about metabolism of drugs. We'll talk about biotransformation of xenobiotics. Remember, this was a more neutral term. Whether that substance has a beneficial or only a deleterious response in the body, we don't care. It's foreign. It wasn't made in that body system. That's all we're studying at that point, and then how the body then works on that foreign chemical. So this was those toxicokinetics. It's all part of detoxifying toxins. Hopefully, as it is detoxified, it will then be eliminated faster from the body. That's the concept, and that's how life has evolved. However, with these toxins, we see that many times they will distribute to more than one compartment in the body. They may even sequester in certain compartments, bone or fat. So a one compartment theoretical estimate of volume of distribution is not appropriate with a lot of toxins. It might be for some drugs to come up with a reasonable loading dose, maintenance dose, and dosing interval using volume of distribution, clearance, and half-life. Wonderful simplification, but often not possible with drugs because of the complexity of the ways that they compartmentalize in the body. And similarly with drugs, we saw that biotransforming so as to eliminate a toxin is similar to metabolizing a drug so as to excrete that drug. But the many ways that you might excrete that toxin could be exhalation through to excretion. It's just all the processes that detoxify the body. But that tier half still applied, whereas we saw with drugs it helps us work out a dosing interval. Here we just wanted to know how many half-lives till you could safely eliminate that toxin down to acceptable levels. We'll never completely remove it from the body. We just want to get to detoxification, which means we've measured some dose estimate of toxicity and we have a low one, or we have a margin of safety that is acceptable. So toxins, as we saw with drugs, often are ingested in food and water. They are xenobiotics, foreign to the body, and they may be a food substance or they may be a contaminant in that food, and they will be absorbed via the gut. They'll go to the systemic circulation, but if they were absorbed by the gut, then they will do first pass first, where the liver will have a significant biotransformation on that particular toxin. However, some toxins never even reach the systemic circulation. They are inhaled, you exhale them. Nothing absorbed. So we've got to look at site of exposure and dose. And with industrial poisons, certain levels of exposure may be acceptable because you don't absorb too much of them at those levels. This will come out in your research if you're doing vapors, solvents, or heavy metals that people might become exposed to due to their occupation or to an industrial poisoning accident. sometimes it doesn't matter about lung absorption, it's absorption through the skin. And so when you look at your MSDSs, they may give you indications of doses that might cause problems because of skin absorption. But the key concept here is with toxicology is that largely your skin is a good barrier to toxins. Sometimes they have their toxic effect on tissues because they're targeting nucleated cells. Well, those keratinocytes that are highly filled with keratin are dead. They have no nucleus, and so they're biologically inactive, and that's why your skin is such a good barrier to toxins. But then again, it may not be, and you may then be able to find some data showing at what doses the skin is no longer a good barrier. And once again, the idea that we're looking at absorption and then distribution to a particular tissue, that may not actually be the tissue where the actual protein target or glycoprotein target or the sensitive cells with their DNA may be. It just may be the tissue to where it compartmentalizes first, so that it may slowly release to another tissue where it's actually more toxic because there's more target molecules. So more on the target later when we look at toxicodynamics. So to continue looking at toxicokinetics, this distribution effect, same as we saw with drugs, if a tissue is very, very well perfused, has a good capillary network, the toxin will distribute there first. But then they may redistribute to other tissues that aren't as well perfused, may have more target molecules, or there may be a binding protein, so those tissues have that higher affinity for that toxin than those well perfused tissues. All in all, this is your body's way still of trying to detoxify and get the majority of that toxin out so that you can eventually clear it from those tissues where it's bound. So one tissue you've got to particularly target in your research is the brain, and so looking at that blood-brain barrier and does the toxin distribute across that barrier. We'll talk about that more when we look at neonates and elderly, some other effects of toxins, important factors to consider when looking at their risk characterization, because certain people are more susceptible due to having a decreased blood-brain barrier. And the half-life was very important. When we said toxicokinetic parameters that need to be measured, half-life determines how long it would take to detoxify, and so something that had a very long half-life is a stored toxin. It has distributed to a tissue where it is sequestered, it stays there. Why it may stay there, there may be a protein such as albumin which might store acidic chemicals. It might bind to transferrin, which usually binds iron. It may even cause that iron to be removed from the transferrin. The toxin might bind to globulins, so it'll bind to tissues where globulins are rich. It might even distribute to lymphoid tissue. It might bind to lipoproteins. It might stay in the blood because of that. Other toxins might actually stay in one tissue because of those metallo-binding proteins. Another name for them, metallothionein. So you can see that they have sulfur in them and double bonded structures. So it gives you a little bit of idea of the chemistry of these proteins that we're making to bind metals and thereby to prevent their toxicity patterns from appearing in other tissues. But it does mean then that they will concentrate in that tissue. And the two very tissues that are designed to eliminate toxins often concentrate them, kidney and liver. Sometimes just the chemical nature of the toxin, organochlorine pesticides, being very lipophilic, sequester to fat stores. So once they are distributed there, there's another compartment where they stay for long periods of time, affecting the half-life, the time by which levels of that substance could be dropped away to half their original on the original exposure. Sometimes you've got to know a little bit about the chemistry and report on it. Heavy metals such as lead won't sequester to bone. It doesn't have much chemical similarity to calcium, whereas strontium, as you all know from the periodic table, has some chemical similarity to calcium and will sequester to bone stores. Fluoride is like this. Then we said one last toxicokinetic parameter to study is biotransformation of that xenobiotic, which was always so as to try and eliminate it faster from the body. The places where that biotransformation could occur, first of all, if it was ingested, then the normal flora bacteria will biotransform a range of foreign substances that come in with the foods or the water that we ingest. We'll see, using alcohol as our example, that can actually have a few problems for our body systems, explaining a few of the mechanisms of toxicity of alcohol because of the normal flora responses. But the major place where biotransformation is going to occur is the liver, same as it was for metabolizing drugs. And once again, same as with drugs, the aim is to detoxify. With drugs, it was to stop their action and help eliminate. But you know, it is possible that these metabolizing enzymes in the liver might also activate a toxin, same as we saw with drugs, that it might change a drug from a prodrug to the actual active compound. So these metabolizing enzymes, let's look at them once again and look at all the terms that are used for them. They are not unique to the liver by any means. It's just that liver cells, hepatocytes, are rich in a particular type of endoplasmic reticulum, smooth endoplasmic reticulum. When fractionated, it comes out with a fraction called the microsomal fraction. It might also come out with the mitochondrial fraction, but it's in the membranes, these proteins. We'll see that they are characterized by their amino acid sequences and put into families, because that determines what the shape of their active site looks like. And so it's found that drugs, toxins, herbs that have a similar shape are metabolized by the same isoform, the same family of these cytochrome P450 or CYP membrane-bound enzymes. So now that the CYP enzymes and other metabolizing enzymes of the body have biotransformed these substances, hopefully they will be more easily eliminated, and generally, if it was an ingested toxin, not only do the gut flora act on it, but it enters the portal circulation first before the systemic circulation, and so you get that first pass effect, where the greater the first pass effect, so long as that detoxifies and prevents that toxin from binding to body targets, then the more beneficial that is. So how wonderful your liver is as that gatekeeper and protector of all that is absorbed from the gut to the portal circulation. At the kidney, we saw that there are often metallo-binding proteins that bind these toxins, sometimes heavy metals, but there are also the transporter proteins that actively excrete them into the urine. And so the health of a person and their sensitivity or susceptibility to toxins might depend upon the functioning of those urinary transporter mechanisms. But more on lifespan issues shortly. Last of all, just one last important point for your research. This won't be relevant to all toxins. There are very few toxins that have an antidote, but if an antidote is known, that is something we want you to report on for your toxin. We've mentioned some examples here simply because we're going to either study these as drugs acting on other body systems later, or we will talk about them being used as antidotes. So we have vitamin K as an antidote for warfarin. Warfarin is the drug that we'll be studying later. Penicillamine and physostigmine we will be studying later for their important effects. With penicillamine, it's a disease-modifying anti-rheumatic drug, and later when we look at drugs acting in the nervous system, we'll be very interested in this neurotransmitter acetylcholine, and we'll see that physostigmine is an acetylcholine esterase inhibitor, a drug that inhibits the enzyme that breaks down acetylcholine, but it's a reversible inhibitor. It's then useful for dealing with overdoses of common substances like atropine, or perhaps not the atropine itself, but the Atropa belladonna plant. So naloxone, we'll study that as a drug. The opioids we will study as a drug system, and so we have an antidote available there. But the one we will talk about in some detail is this antidote, N-acetylcysteine. It's the antidote in paracetamol overdose, and we'll see why shortly when we see that paracetamol, or not it itself, but a toxic metabolite of paracetamol, reduces the amount of available glutathione in the liver. Glutathione being that really important little tetrapeptide. Now, being an antidote and taken as a drug, all drugs have adverse drug reactions. Being an antidote, it's usually given in quite high doses too, so you have to know the adverse effect. So if your toxin has an antidote, report on the toxin and report on its toxicity profile. So here for N-acetylcysteine, which we've given as our example, we have that it produces a mild anaphylactoid reaction. Note we don't say it's an anaphylaxis. That might be a toxicity mechanism for some of your toxins, especially if you're doing envenomations and other toxins from living systems. But here with this particular substance, it leads to an angioedema. So tissues that are capillary rich compartmentalize their plasma into another fluid filtrate, an edema in the tissues itself, but because they're capillary rich tissues, you get a flushed reaction, you get a flushed skin, or you get a rash. It doesn't occur in the systemic circulation. You don't get a massive drop in blood pressure, so it's not anaphylaxis. It's just in the skin or other sensitive tissues, and so it's a mild anaphylactoid reaction. So here is the toxicity profile for paracetamol. You saw that it was, it's not even Schedule 3 with pharmacist's advice. It has even greater access and available in shopping centres, in most people's homes, but with children it can just look like a bunch of lollies to them. And don't worry that you'd think that they'd be stopping taking it once they realised it wasn't sweet. Oftentimes that's not the intention of putting things near the mouth with really young children. It's that they have so much tactile sensation from the mouth. That's how they experiment and explore things, whereas an adult would feel it with their fingers. Children will feel it with their mouths and then swallow. And so it's very easy for children to overdose on paracetamol. So it's not an adverse drug reaction, it's an adverse drug event, an overdose situation. So normally we saw that paracetamol might be metabolized by various enzyme systems in the liver and perhaps other tissues of the body, but particularly the liver with paracetamol, and that includes metabolism by a particular CYP fraction. The other name for those, the mixed function oxidases, telling you the sorts of reactions that the CYP do, which was those oxidation reduction or hydrolysis type reactions and so on. So paracetamol is metabolized to a particular toxic metabolite, an imine, NAPBQI, and it's this substance that actually depletes glutathione, your important reducing agent that you have in your liver. abbreviated to GSH, to show its thiol group, its sulfhydryl group there. That's not an acronym. And as the levels of glutathione deplete because the person has taken the paracetamol in such high amounts, beyond the amounts that would normally just be sulfated or conjugated with glucuronide so as to remove it. This is not therapeutic doses of paracetamol where that happens. This is overdoses where the CYP fraction kick in and glutathione levels go down. And so you'll see as they go down you get oxidative stress. Certain other changes that will then go on due to that oxidative stress. It'll kick in a lipid peroxidation reaction that will decrease the permeability of membranes in those hepatocytes. This will lead to high levels of calcium in those tissues, and that will stimulate many enzymes that are then degradative. They will break down the structures in those hepatocytes because of those continually high levels of calcium. So that's the level of detail that we want you to go to with your mechanism of toxicity. You may not do it for all of the toxic profile of your substance. The other ones you may put in appendices or data tables, but in the body of your essay we want you to explain one mechanism of toxicity in a fair bit of detail, down to the biochemical level.